Hi, everyone. My name is Joy Abayami, and I'm a general surgery resident at the University of Michigan. Today, I'll be presenting our study on the impact of CYP3A5 status on the clinical and financial outcomes of African American kidney transplant recipients. I have no disclosures. CYP3A5 is a cytochrome P450 enzyme that plays a role in the metabolism of a number of proteins and medications, one of which is tacrolimus. Tacrolimus is, of course, one of the primary immunosuppressing medications used in solid organ transplantation, including kidney transplants. However, the expression of the CYP3A5 gene, and therefore the expression of the enzyme, is quite variable between different ancestry groups. From a genetic perspective, the CYP3A5 gene has had a significant amount of selective pressure, perhaps due to its role in vitamin D metabolism and the need to optimize vitamin D stores in places with minimal sunlight. But in the transplant world, this leads to a situation where transplant recipients have the potential to metabolize tacrolimus in very different ways. The vast majority of patients of European ancestry express the STAR3 variant of this gene, which is a non-functioning version. This leads to slow metabolism of tacrolimus and allows the drug to build up to a therapeutic level in the system easily. STAR1 is the designation given to the functioning version of the gene. As you can see, the allele expression among those of African ancestry is quite different. The allele frequency of the STAR1 allele, which is again the fully functioning protein, is roughly zero point 0.5. This indicates that patients of African ancestry are more likely to express a working version of CYP3A5 than those of other backgrounds. However, even the non-functioning alleles that are present in this population differ from other ancestry groups, with STAR6 and STAR7 variants representing non-functioning alleles that are really only seen in patients with African ancestry. Having two functioning alleles would designate you as a fast metabolizer. One mutation or loss of function allele would make you an intermediate metabolizer, and two loss of function alleles makes you a slow metabolizer. As you can imagine, patients who quickly metabolize tacrolimus are at risk of having subtherapeutic levels of immunosuppression, which can lead to episodes of rejection and increased variability in their trough levels. This could also lead to more healthcare costs, as these patients may have some more complications requiring blood work, hospitalization, or procedures. In our study, we wanted to see if metabolizer status or a patient's genetic data correlated with any clinical or financial outcomes. It was a great partnership among several institutions. We were able to use the genetic data collected at Penn Medicine with iGene Train, coupled with the clinical knowledge from collaborators at the University of Iowa and St. Louis University, with access to the data on graft survival and Medicare spending in the SRTR. We looked at 286 African American kidney transplant recipients from Penn Transplant Institute. In our population, 23% of patients were fast metabolizers, 47% intermediate metabolizers, and 30% slow metabolizers. In looking at the incidence of various events, we see that the incidence of death is higher among fast and intermediate metabolizers than slow metabolizers. The rates of death censored graft failure and deaths and all-cause graft failure were also higher among fast metabolizers. When looking at Medicare spending, we see that intermediate metabolizers had on average roughly $4,400 less spending or less healthcare costs than fast metabolizers, which was significant. Slow metabolizers also had less spending costs than fast metabolizers, though this was not significant in the end. In conclusion, CYP3A5 status does appear to be associated with different clinical outcomes and healthcare spending. Given that there is significant variability in CYP3A5 genotype among African Americans, this could be a contributing factor to the disparities in kidney transplant outcomes that we persistently see in the literature. We know that there is a 5% lower 5-year graft survival for African American recipients than for Caucasian recipients in the United States. There could truly be a benefit to performing a pharmacogenomic assessment and perhaps genotyping patients, specifically African American patients, prior to transplantation in order to guide immunosuppression, improve disparities in outcomes, and reduce immunosuppression-related side effects. Personalized immunosuppression would also help us to stop using race as a proxy for genetic variability and to specify our treatment regimens to the specific genotype of the individual. This personalization could lead to improved spending as well, which would definitely be beneficial in a field as expensive as transplantation. There's certainly a lot of work to be done on this topic, and additional prospective work is needed to see what true healthcare savings and clinical improvements could be gained. But this study suggests that this is one area through which we could work to address racial disparities in kidney transplantation. Thank you very much for your time, and I'm happy to take questions at the end.